So I'm going to start with a few preliminary comments before I get into the main part of my talk. And mention briefly parameters of psychosexual differentiation, and this particular perspective has influenced some of the work I do. We start with sex/gender assignment at birth, and then three parameters: gender identity, gender role behavior/expression, and sexual orientation. And this model emerged many decades ago, and it might be considered a normative sex difference model, meaning that if you look at these three parameters, gender identity, gender role, and sexual orientation, on average, there are very strong sex differences. And Professor Biggs sort of pointed that out with regard to gender role behavior in his talk. And the classical temporal sequence model is that gender identity develops first, followed by the adoption or expression of gender role behavior, and then sexual orientation emerges later in development. Now, in the classical model, there is an interrelationship assumption, meaning that if there is a shift in one parameter, the odds are going to increase that there'll be a shift in another parameter. And theoretically, then, the idea is that in terms of causal mechanisms, that there may be common underlying factors that are related to all three. A bit of additional history about the diagnosis of gender identity disorder and gender dysphoria. The diagnosis first appeared in the DSM-3 in 1980, gender identity disorder of childhood, and then transsexualism for adolescents and adults. And if we move up to 2013, we have the diagnosis of gender dysphoria with separate criteria sets for children versus adolescents. Now, for those of you who are familiar with the history of psychiatric nosology, the DSM-3 was a watershed and revolutionary development in Western psychiatry in that they moved to more precise diagnostic criteria and much more well-defined than in DSM-1, 1952, and DSM-2, 1968. And basically, why did gender identity disorder of childhood and transsexualism make their way into the DSM-3? Two reasons, and you can decide which reason I'm sort of joking about. One was that a diagnosis was considered for entry if it could be made reliably and if one could provide reasonably descriptive criteria. And two, given the revolution in American psychiatry with DSM-3, you want it to be inside the tent and not outside it. Now, my talk is going to be about what we know about the long-term gender developmental trajectories of children. Although I know that a lot of folks who are at this meeting are much more interested in adolescence these days, as am I have to say. But when I first began working in this area in 1975 in Toronto, at the age of 24, when our clinic in Toronto started, we saw more children than we did adolescents. And you can see in this slide grouped at 4-year intervals, that at the beginning, the clinic in the mid-70s, we're seeing more children. That started to increase pretty dramatically by the early 80s, but it was really only until the mid-2000s that we started to see more adolescents. So early in my career and in the clinic, we focused a lot more on developing research with regard to children. Just to follow up a little bit on Professor Biggs's comment earlier, in the DSM-5, which was published in 2013, there are these 8 criteria, of which you need to meet at least 6 of them to get the diagnosis, including A1, a strong desire to be of the other gender, or an insistence that one is the other gender. Now, one of the things we did many years ago was just kind of do a qualitative study. Why are little kids referred? So when I'm talking about children today, I'm talking about kids that we saw in our clinic anywhere between the age of 2 years and 12 years. The mean was about 7. And these were, I would say, the most common reasons that a referral was made by parents or a family doctor or a teacher. They felt the child had gender dysphoria or was unhappy about their gender, concern about social ostracism because of gender variant behavior, that these kids had other mental health challenges, which has been a pretty common finding in our work over the years. Another parameter was family dynamics. So, for example, the parents might feel that something was going on in the family that was contributing to their child's gender dysphoria, and then also concern about their child's sexual orientation. That is, parents wondered, does this mean my child's going to grow up to be gay? And some parents didn't like that. Now, these are follow-up studies in the literature of children. And I'm going to tell you a little bit about what have we learned from these follow-up studies in terms of persistence and desistence. The earliest follow-up study was published in 1968, and then the most recent one by our group, Singh et al. In 2021. Most of you are probably familiar with most of these studies, although you may not recognize the one by Nakamura, which I actually just added to this slide. This is actually a PhD thesis that was done at the GIDS, the Gender Identity Development Service. And it's a PhD thesis with a huge sample of 4. But there's a really funny story about that thesis, which I'll tell you about later. I only have 30 minutes. But getting a hold of the thesis was an adventure complicated by COVID, but I'll tell you about it later. But these are the follow-up studies of children. And again, remember, I'm talking about kids who were seen for the first time anywhere between 12 and, let's say, age 3. Now, it is important, and this actually is quite connected to something Professor Biggs was saying this morning. To understand the therapeutic context of these follow-up studies, what kind of treatment, if any, did these kids get who were written about by these various clinicians or researchers. Some of the kids might have had an assessment of some type, but didn't have any treatment. Another unknown number of these kids might have had an assessment, and then maybe the recommendation was, don't do too much of anything, which is known as wait and see or watchful waiting. A couple of years ago, I was writing something up, and I wanted to trace back who first came up with the term watchful waiting, because I really have no idea what it means. But watchful waiting was preceded by some papers by a child psychiatrist in the States named Eduardo Menviel, who talked about wait and see, which is basically the same thing. But I really surprised myself in tracing who first used the term watchful waiting. It was actually me in an editorial I wrote in 2008. And that activated my PTSD because I really have no idea what watchful waiting means. And everybody says that's what I do, but I don't know where that came from. And then another treatment that many of these kids had, which I'm calling treatment 2, recommendations to parents to implement a naturalistic environment, parent counseling, behavior therapy, play therapy, psychodynamic, psychotherapy, group therapy. Basically, the theoretical and philosophical perspective of the clinician would recommend whatever they kind of did anyways with any kid. So the treatments are quite variable. Okay, so, Richard Green, the psychiatrist who, for example, was one of the first people working in this area. He was one of the co-founders of the predecessor to WPATH, the Harry Benjamin Gender Dysphoria International Association. He once wrote, "The name of the game is follow-up." And to which I would add, and you have to live long enough to follow up your patients. So I was 24 when I saw the first patient in our own follow-up studies, and I'm a little older than that. But if you look at across all of these studies, this is what we know about persistence of gender dysphoria in kids who are seen for the first time in childhood. So in these early studies, small samples, 8%. In Richard Green's study, 2%. In 2008, the Dutch reported 20% persistence in birth-assigned males, 50% in birth-assigned females. We published our study of birth-assigned females in the same year, 12% persistence. And then in 2021, we finally got around to publishing our data on birth-assigned males, 12% persistence. The Steensma study in 2013, I'll talk about later. So in Toronto, the persistence rate was very similar for the birth-assigned females and males. A slight sidebar. In Richard Green's study, which he summarized in his book in 1987, he reported data on sexual orientation as well. And so he uses the Kinsey scale. For those of you not familiar with it, you dummy code from 0 to 6. 0 to 1 means you're exclusively heterosexual. If you're born male, meaning you're gynophilic. 2 to 6, bisexual to completely same-sex attracted. So exclusively androphilic. And he measured this both in fantasy and in behavior. he also had a control group of typically developing masculine boys. And what you can see is that in Green's study, 75% of the feminine boys were bisexual or exclusively androphilic compared to none of the control boys. And in behavior, very similar finding. So same-sex attraction, as Professor Biggs alluded to earlier, is highly associated in this follow-up study. And in Toronto and in the Netherlands, very similar findings about sexual orientation. These are data for birth-assigned males. So very high percentage of these boys, when you follow them up in late adolescence or young adulthood, are same-sex attracted. Now, we get into the meat of some things. Criticisms of the follow-up studies. Some people hate these follow-up studies, and I'll say why, but in a minute. But you know, one criticism could be method variance, which is reasonable. I mean, in the early studies, there weren't standardized measures. There wasn't even a diagnosis. That's fine. Over time, the studies got better. Another criticism of the follow-up studies is that for those of us who use the DSM criteria, we did include kids in the follow-up studies who didn't meet the full criteria for gender dysphoria when they were first seen clinically. And that's a reasonable criticism, which I'll come back to. Some critics have jumped all over my Dutch colleagues because they weren't able to follow up all of their cases, which is normal in any kind of research. But the Dutch classified their non-responders as desisters. And their argument, which I think was quite reasonable, was, look, we're the only clinic in the Netherlands. So if a kid continues to have gender dysphoria and wants to do something about it, they got to come see us. And that's not a bad argument, I think. And not only that, they also looked at their baseline data of the non-responders to the kids who were in the study, and there didn't seem to be any major difference between the kids they couldn't trace or couldn't find. And we've done the same thing in Toronto in the sense that we weren't able to follow up all of our kids, but we would compare the ones in our follow-up studies with the ones we couldn't find or whatever. And basically they seem similar at baseline, which makes me feel reasonably comfortable that we weren't scooping in for follow-up an unrepresentative sample. And then there's the no true Scotsman argument, where the people who hate this research says, well, the desisters were not truly gender dysphoric to begin with, so there was nothing to desist from. Only persisters were truly gender dysphoric. And I figure since we're close to Scotland, I should talk about what the no true Scotsman is. No Scotsman puts sugar on his porridge. But my Uncle Angus is a Scotsman, and he put sugar on his porridge. But no true Scotsman puts sugar on his porridge. So you can't really win. But I take the criticism seriously. And so one of the things we could look at in the Dutch studies and in the Toronto studies is, well, what if we look at the DSM criteria and separate the kids as a function of whether or not we said they were threshold or sub-threshold for the diagnosis. what does that tell us? And so what this slide shows is the percentage of kids in these 4 studies where we gave them the complete diagnosis. And you can see that of the kids that we gave the complete diagnosis, and we're looking at those who were persisters, you can see that 90% of the persisters were threshold for the diagnosis. Only 10% who turned out to be persisters were subthreshold. So that's important to note. But then look at the desisters. So where we had 280 desisters, and of those 280 desisters, almost 60% were given the complete DSM diagnosis from in childhood. So at least, unless you basically want to say the diagnostic criteria for gender dysphoria in childhood are bad, it seems like they did desist from something. And so I would say to the critics, you do something better than what's been done so far to make your argument. I'm going to skip that. So I do believe, based on the 4 studies that use the DSM criteria, that a lot of kids did have gender dysphoria and they desisted. Now, these follow-up studies that I've mentioned, and this also builds on something Professor Biggs was talking about, were assessed and sometimes treated prior to the emergence around the mid-2000s of pre-pubertal gender social transition, which is really an alternative type of psychosocial treatment designed to reduce gender dysphoria. It's a treatment parents may have instituted on their own in consultation with a clinician or on the advice of a clinician or some other type of professional like a teacher. And so social transition is viewed by many, therefore, as an example of gender-affirming treatment. But in all of these follow-up studies I've talked about, with the exception that's about to come, as far as I can tell, nobody had socially transitioned as a type of treatment in childhood at the time they were first seen. And these cases go back a long ways. The earliest case in these follow-up studies was seen in 1954, and the latest 2008. Now, pre-pubertal gender social transition now has become a much more common approach to kids who are being seen in childhood. This is a book by Tay Meadow in 2018. And we've already started to see pictures of Jazz Jennings from Professor Biggs, but you know, Jazz was an early onset birth-assigned male with gender dysphoria. You showed the picture with Barbara Walters on ABC television. I am Jazz. And, you know, a key page in the Jazz book is I have a girl brain in a boy body. This is called transgender. I was born this way. Now, clinic-referred studies, or patients clinic-referred. So the Dutch did report in 2013 the first follow-up study of children in which some were classified as having had either a partial or complete social transition prior to puberty. And these are, I think, important data which are anticipatory of what we're going to see down the road. So Steensma, this is a slide of birth-assigned males, classified them into two groups, those who had made a partial or complete gender transition in childhood versus those who didn't. And you can see that of the 23 persisters in their follow-up study, which is the pink bar, around 45% had partially or completely transitioned prior to puberty, compared to very few of the desisters. Similar pattern for the birth-assigned females, although this difference isn't significant. But the hint from the Steensma study is that social transition in childhood may be a predictor of persistence. This is a slide of data from Toronto. It's not published, but the data are pretty cool. Of 156 kids that we saw for the first time in childhood between 2006 and 2015. Why 2006? Because that's when we first started to see kids coming into our clinic who had already socially transitioned. And I took a peek at some variables comparing the 22 who had socially transitioned before we saw them against the 134 who hadn't. The percentage of males and females who had socially transitioned wasn't significant. The ones who had socially transitioned were significantly older, 9 versus 7, similar in IQ. They came from on average, slightly lower social class background. They were way more likely to not be living with two parents. All of the ones who had socially transitioned were diagnosed with gender dysphoria, compared to 77% of the ones who hadn't. And then on two-dimensional measures we use, the kids who had socially transitioned were more extreme at our baseline assessment. So some of these data, suggest there are correlates of social transition, but that's a whole other story. Now, one of the great sea changes, I think, that is happening in specialized gender clinics in the time we're in now is that more kids are coming into clinics prior to for their first visit, and that they have already socially transitioned. These are data that were just published in Archives of Sexual Behavior by Morandini from the GIDS in London. Children ages 4 to 12 who had socially transitioned prior to their first appointment. And, I look at these numbers and it's incredible compared to the older days. So of the 27 females, 74% had already socially transitioned, 86% of the males. And when you talk to other clinicians at other clinics around the world, this has become much more common, that kids are coming to a clinic and they've already socially transitioned, some at very young ages. So you can ask, why do they come to these clinics? If they've already socially transitioned, what do they need or want? And some colleagues tell me, they say, well, we just want to get on your list, so when our kid approaches puberty, it'll be easier for us to see you, and so on and so forth. Now, a few years ago, I wrote that as samples of socially transitioned children become available, it's my prediction the rate of persistence will be much higher when compared to the older studies. where most of the children received either what I'm calling treatment 1 or treatment 2. A study last year by Christina Olson, not to be confused with Joanna Olson Kennedy, published a paper in Pediatrics that lends support to this prediction. In her study, there are 317 children not recruited from clinics. So they're recruited from like Facebook pages, meetings of parents who have kids who have socially transitioned or thinking about it, word of mouth, snowball sampling, that kind of thing, who had socially transitioned at a mean age of 6, entered the study at a mean age of 8, followed up on average 5.4 years later, so beginning of adolescence. And in her study, she reported that the persistence rate was 94%, which is so different, even though these kids are still young, than the older follow-up studies. Now, in the older follow-up studies, desistance rates show that gender identity becomes more congruent or compatible with birth-assigned sex in the majority of cases. Social transition as another type of treatment, we could say leads to a different kind of desistance. The gender dysphoria presumably dissipates because the child is now living in the desired gender. However, for desistance to remain stable, it will often, if not always, require biomedical treatment, hormone therapy with or without surgery. So one could say there are different pathways to desistance. And so the parental conundrum, in my view, might be that which therapeutic approach should one take to reduce gender dysphoria? And on this point, there's incredibly intense debate. Do you recommend an early gender social transition? Do you watchfully wait, although nobody knows what that actually means? Psychoeducation, developmentally informed psychotherapy is a term I just made up because I realized we need to say what we think we do. So DIP sounded like a good acronym. And, I wrote about this in a journal a few years ago, Different Strokes for Different Folks. And I guess I would say that I don't think any of these approaches needs to be privileged over the others until we have more data. And I also don't believe that any particular psychosexual outcome needs to be privileged over others. I think my main point is parents just need to know what the odds are that one approach versus another, where it may go. But to decide what is the optimal therapeutic approach, we need very different kinds of data. So that's it. Thank you.